So
So now I invite Dr. Bhave, and then we can
yes,
have question
then we
and
can have
answers. And
if we have
again,
time.
one more surgical challenge after vertical rectus and oblique muscle surgery. What are the residual deviation? Thank you very much, Dr. Bhave.
Yes. So, I'll be talking today on managing residual vertical and oblique deviations after having operated them. No financial interest. So, the topics I've covered in this are persistent DVD after surgery, persistent inferior oblique overaction after surgery, and there's another interesting case of persistent vertical deviation after surgery. So persistence of DVD, I always say it's devil never dies. Dissociated vertical deviation involves both the eyes but is often asymmetric. It may be manifest or latent and was first described by Stevens in 1895. DVD occurs in the context of infantile esotropia or early onset exotropia and is associated with intense disturbance of binocular vision in the early life. There are plethora of procedures described from non-surgical to multitudes of surgical procedures, indicating that none of the procedures have a very satisfactory outcome. These are various surgical procedures which are described for DVD. And this coming to the first case, this was a 6-year-old female. She had an alternate esotropia with aesotropia with DVD. The ocular movement showed no significant oblique overaction. Prism bar cover test showed a 45 to 50 prism diopters for distance and near. So she was diagnosed as infantile esotropia with DVD. And she underwent, this is a very old case of mine. I did a MR recession with SR recession and Faden in one eye, and a LR resection with SR recession and Faden in the other eye. I didn't want to tackle 3 muscle in one eye, so I split the ESO correction in 2 eyes. I wasn't doing plication then. So after she had a straight eyes after the initial surgery, but after 17 years now she comes again with a consecutive exotropia with right hypertropia and persistent DVD with left eye was dominant, and now the deviation was about 30 prism diopters exotropia with small R by L. There was also some adduction deficit, as Dr. Ramesh was just now emphasizing, that we'll look at the adductions. So she had small adduction deficit. So explored her right eye. It was found, the MR was found to be attached at 5.5 millimeter where I had placed it initially, slightly superior to the original insertion. So we detached it, advanced by 4.5 millimeters and downshifted by 1/3, because I had already recessed the superior rectus with Faden, so I didn't want to do another rectus muscle for her DVD. And recessed lateral rectus 6 millimeters and again downshifted by 1/3 breadth. So 2 months post-op, she had relatively straight eyes, but some amount of DVD persisted. This is a small video of posterior fixation of superior rectus. We really need to go much back, and nowadays I don't have the heart to do this surgery. I used to do it previously. About 14 millimeters behind, we're taking a non-absorbable suture on the sclera. And if we are combining it with the recession of a superior rectus muscle, then the muscle bite, we take it slightly forward. So if we are doing a 6 millimeter recession, then I would take a muscle bite at 8 millimeters on the muscle. So similar procedure is repeated on the other side. The vicryl sutures are given to the muscle in the usual manner, and after recessing the muscle by whatever amount you have decided, we tie the suture on the sclera, the Faden suture on the sclera. So we are combining recession with Faden in this case. So coming to the persistent inferior oblique overaction, the inferior oblique overaction after disinsertion procedure is seen maximally after inferior oblique mymectomy. This could be because of insufficient retraction of the muscle in the subtenon's place, reattachment of the fibers to the sclera, and seen in as high as 75% of cases. Even after recession of IO, in overaction is seen in about 12% of cases. Most stable results were found after IO80. Now, this was another interesting case. A 25-year-old female, she came with history of surgery done twice. Once already in the childhood, the records for which were not available. And second surgery was done 3 years back, bilateral inferior oblique myectomy with left eye RNR was done. But when she came to me, she had a significant exotropia. It was 35 prism diopters with almost 30 prism diopters of R by L. And this R by L was more in the left gaze and more on head tilt to the right side, indicating she had persistent inferior, you can see on the right side. R by L more and more whenever when she is tilting her head to the right. She was habitually fixating with the right eye, so it was not getting very much manifest. So what to do now? Because left eye RNR was already done, both eyes mymectomy was already done, and so I thought I'll explore the left eye and see which muscle is, the medial rectus on that side didn't seem to be. And so on exploring the right eye, we found that there were a lot of adhesions in the area of lateral rectus and inferior oblique. The lateral rectus was found at 7.5 millimeters. So could not do much about it. The pseudo tendon and all I cleared and left it like that because of too much adhesions. I couldn't find inferior oblique. So did a plication of 7 millimeters in the of the medial rectus, and then left eye inferior rectus recession of 4.5 millimeter was done. So this was post-op, though the exo did not get corrected fully, but she was much better than the previous as when she came, and even the some amount of hypertropia also remained. So this is another case. She was a 1.5-year-old female, came to us with a large angled esotropia and grade 4 inferior oblique overaction. She underwent bilateral medial rectus recession 10 millimeters from the limbus and in bilateral inferior oblique recession with anterior positioning at 0 station. This was the post-op period, but after 6 years, we found that there was some residual R by L. Again, R by L was more in the left gaze and right head tilt. So indicating persistent right inferior oblique overaction. So then she underwent a nasal transposition of inferior oblique, and this was the orthoptic examination after the second procedure. So this is the video after second surgery. Still there was minimal R by L, but she was much better than before. We thought there could be some element of DVD too in this case along with inferior oblique overaction. This is a small video of anteronasal transposition of inferior oblique muscle. Inferior oblique is cut. It is sutured. I'll just forward it slightly. And then it is brought on the nasal to the inferior rectus and then sutured at the level of inferior rectus. That is how we do the nasal transposition of inferior oblique. And it's quite a strong procedure we need to do in whenever there's a persistent inferior oblique overaction. Yes. So this is how they sutured nasal to the inferior rectus muscle. Now this is the last case. This was a 6-year-old female, came with a history of strabismus surgery done in the past for ESO. They said even the eye was hypo, no records were available. The father could not tell much. He said some minor surgery was done. There were some marital issues in the parents, and the parents had separated, and he said that mother had all the records, so he didn't know anything. So when she came to me, she was having this esotropia, large esotropia with large hypotropia and a head posture. So there was an underaction of left eye in elevation, adduction and elevation. So it was looking like an acquired Brown's with the esotropia. Elevation was better in the abducted position, but in adducted position, elevation was significantly restricted. Then there was a huge conjunctival cyst of 8 millimeters in the region of superior rectus. Rest of the ocular movements were okay. So there was this large conjunctival cyst in the region of superior rectus. I asked again, pointedly took the history, could get the name of the surgeon. So I spoke to the surgeon and asked as to what was done. So she told me that a bilateral medial rectus with bilateral inferior oblique recession was done. So again now what to do, since bilateral medial rectus was done. So we explored her left eye first. And left eye first, the cyst was removed. I thought it was related to the muscle, but it was a simple cyst and not attached to the superior rectus. Left eye LR plication I did of 8 millimeters, and there was so much of fibrosis that I didn't feel like touching on the medial side, and inferior rectus recession of 4 millimeter was done in the left eye. And in the right eye, I thought I would try to increase the MR recession, but it was already recessed at 5.5 millimeters. So partial tenotomy I did and did a LR plication of 8 millimeters. So at 1 month post-op, I don't know, the head posture didn't correct, though the eyes looked fairly okay from horizontal point of view, but the hypotropia still remained. It's less than before, but hypotropia is still there. And the elevation did not improve. I thought after removing this cyst, maybe the elevation will improve, but elevation did not improve. Yes. So take-home points is obtaining history of previous surgeries is very important, as it aids in further surgical management. Each case should be assessed according to its merits and demerits. The choice of surgical procedure depends on former surgery done, surgical dosage applied, residual decision, surgeon's preference and experience. So this is our team, and I invite you all in December 7th and 8th for the annual SPOCI meet at NAC.